Morning, Mark. How are you? Shauna Hudson. I head the community engagement core, and you've been working with our staff, so we're really excited to talk with you today.
Yeah, me too. So we're awaiting Beth and Jennifer and Gardan from the Boys and Girls Club in Newark.
Thank you everybody for joining. Today we're going to be talking with the Youth Development Clinic, and so Dr. Kitsy and his team, they're going to be giving a brief presentation about their project, and they're hoping to get some feedback from some of our experts on the call. So just a couple of kind of ground rules. We ask that you stay muted when you're not speaking. If you do speak, just introduce yourself first so we know who is talking. And of course, be respectful and supportive of one another. So let's kick things off with some introductions. If I call your name, you could just unmute and introduce yourself to the group.
So our objective and our purpose for being here is to kind of get some support and guidance in our initiative to develop some community-based clinics. Our goal is to develop these community-based Medicaid outpatient clinics within various neighborhoods in Newark, New Jersey. We do have a clinic right now based in the Central Business District, right on Broad Street. And we serve the entire Newark community as well as Kearney, Elizabeth, and other areas as well. But often our clients face barriers to access some services within our agency. So we're really looking to really create some community-based clinics to facilitate prevention as well as earlier intervention, really to kind of meet the clients where they're at and reduce those barriers that the clients face to access services. So one of the things that we are looking to do is increase access to mental health services. So being in a space where we're meeting the clients where they are rather than them coming to us, with the overall goal of reducing the racial and economic disparities between those who are able to access services and those who cannot. A big barrier to services for many of our clients is things like transportation. So we frequently have clients that don't make it to session because they don't have enough money for a bus pass. And so really kind of reducing some of those even very simple barriers, and serving to decrease stigma and strengthen community resources. So as we'll talk about today as we go through the presentation, really pairing with other community agencies and being part of agencies such as the Boys and Girls Club to strengthen resources in the community and provide mental health services within agencies that may not be providing those services already.
So the YDC, as Dr. Barbarash mentioned, serves primarily individuals who live in the Newark or greater Newark community. And what we've determined in terms of our population is that approximately 87% of our clients are at or below the federal poverty standards. And we service a large range of individuals. So predominantly our clients include children from birth to age 18, as well as their family members, other caregivers. So we provide individual-based services as well as family-based services. So we do particular skill building, so parenting, focusing on other mental health needs, anxiety, depression. A lot of our clients, because of their backgrounds, come in with trauma histories. So we provide services for that as well. And we're very diverse in terms of our race and ethnicity, linguistic background, as well as gender and sexual orientation. So we have a wide range of the clients that we serve in the community. And the reason that we're trying to focus on bridging the gap is because, as mentioned, we have accessibility remains a significant obstacle for a lot of these clients. And especially when it comes to scheduling constraints and providing transportation or having our clients access, being able to come to the clinic for services has proven to be difficult for them. And seeing the difference, especially just anecdotally with providing telehealth now, where kind of bringing the therapeutic environment to them has been helpful. So we're trying to increase that and continue through these community-based clinics.
This is kind of just a brief summary of our current data collection processes. We measure success based on both process and change outcome. So a big measure of success for us is something as simple as attendance rates. As we discussed, our clients face a lot of challenges and struggles throughout just their daily, lives. And so attendance is a huge data point for us. Are our clients consistently showing up for their sessions? Because just even the matter of showing up indicates that this is something that's important to them, that they value. We administer the client satisfaction survey, which is based on a Likert scale of 1 to 4, 1 being that is the lowest and 4 is the highest. And overall, our ratings indicate that clients feel safe, supported, and cared for by our clinicians. And most importantly, saw improvements in themselves as a result of the treatment they received.
We also provide individual counseling to children, including for a variety of different presented problems, including anxiety, depression, ADHD, aggression, and trauma. We also include parent trainings and parenting skills to help facilitate what we're doing in individual counseling so that parents are also aware, and we can sort of create this integrated form of treatment. We provide family therapy as well as psychological evaluations. And currently we don't have a psychiatric nurse at our clinic, but we intend for in their community-based clinics to have a psychiatric nurse who can provide medication prescriptions as well as management. And that nurse would be supervised by a licensed physician.
As you might have already have a history of this, but so that I understand logistically what you're talking about in terms of the community partnerships that you're attempting to set. Do you have locations? Do you have those partnerships already in place for the different wards? And has that process already started, or is that part of what you're looking for in terms of impact and community agencies who may be able to partner with you?
Well, yeah, the process is started, and we want to expand upon it. One of the reasons we asked Gardan to join us is because we were kind of ready to go with setting up a clinic at the Girls and Boys Club, and then the pandemic hit. So perhaps Gardan could speak a little bit toward that kind of partnership. But as I said, we also have partnerships with the I'm trying to think of their actual name in the Ironbound community.
Ironbound Community Corporation.
There we go. Yeah. Ironbound Community Corporation. And they have 3 sites that we were talking about. I went and toured them, and we got pretty far with that. And also, in schools, public and private schools, some of which we serve through grant-funded services, are interested in if they have, a room for us, being able to set up an in-house, clinic, mental health clinic. So that's kind of where we're at so far.
Great. And you may want to consider too Hetrick Martin Institute as well. And
absolutely. Yeah, we need that. That's right. So that you put your finger on an organization that I'm really interested in, getting to know better. They're right down the street from us on Broad Street. And, we do service some, obviously LGBTQ clients. They're in this case, mostly adolescents who we do look for Hetrick Martin for kind of supportive services. So we also engage with the Newark Library. So, they're across the street from us in Washington Park. So we're looking to be able to provide some mental health services as part of their programming as well.
We at the Boys and Girls Club, we actually have quite a few health services that we provide, including pediatric dental care, as well as mobile vision care. And so we have a wellness center currently, but part of the challenge is that we rely on students. I am the only licensed practitioner in the entire building, and in our entire program, we service roughly about 530 kids during the academic year. And then during the summer, we service about 300 children. And so a good portion of our membership are children who are dealing with ADHD or depression. And so a lot of times those kids are coming into my office. And so I'm utilizing a lot of times interns who, as we all know, are in the process of learning themselves. And so it's become quite difficult. And so I actually had reached out to Dr. Kitsy and said, hey, can we talk about what can a potential partnership look like? Because I cannot be the only clinician in the entire building doing a lot of this work. And although having interns is great, we know there's a low threshold because they come in for about 8 to 9 months and then they're leaving. And so what's happening, we're having to refer our children out a lot when they are presenting with a lot of crises, and we can't, or crisis, excuse me, and we can't necessarily support them in-house, which is what we would like to do. That's the reason why we have health services in-house to support our kids, because we're trying to also eliminate the barrier of parents having to leave work or pull the children out of school for support services, where yet they can do it all in a traditional after school or summer program.
Do you primarily use sort of individual models, or are you also doing like group models for parent training in particular?
We are not currently really focused on group models. One model we started to get off the ground was we had a number of clinicians trained pretty intensively in DBT, dialectical behavior therapy. So we were looking to, we actually did start some groups for parents with, emotional regulation problems, but that was more through our division, child protection and permanency referrals. Groups are really challenging. We do some groups in our schoolwork, and that works because there's a captive audience and we can go and grab the kids from the classrooms. But, to get a, group of people together for a group at our clinic is more difficult. We might be more successful with that in a community setting, particularly something like Boys and Girls Club, where, there may be a group of kids there anyway. And if we have a, group schedule, they're just be more likely to have more consistent attendance.
I just want to add one other person in Newark who might be really interested in kind of what you all are doing. So the Believe in the Healthy Newark initiative has done a lot of work around adverse childhood experiences. And so sort of given sort of the frameworks that you're talking about, trauma-informed cognitive behavioral therapy, parent training, there may be a lot of overlap in terms of the interests.
And then I just wanted to chime in a little, as a mental health services researcher, that I can maybe address a little bit of the second half of the question around assessing for reduction in disparities in access to treatment. And in particular, what I would just say in that is that it's actually very hard to get population-based samples of need in mental health. It's just tremendously challenging. And so one way that we often assess for access to services is looking really carefully at the data of who is accessing services. And if you see particular populations that you're intending to address, whose needs you're intending to address, getting an uptick, right? So really having good measures that recognize and can track over time the racial and ethnic diversity, the language diversity, the communities from which they're coming, but building up the infrastructure, which maybe sounds obvious, but I know that it can be quite a lot of investment to get good indicators to recognize the diversity of the individuals that are accessing services. And so as a first step to assessing for access, I would actually flip the question and look really closely at whether or not those that are receiving the services are fitting the disparity populations that you're particularly intending to try to address, to reach.
So Dr. Mackey, if you have any measures or approaches in particular, we certainly would look forward to getting any further information about that.
Yeah, I'm happy to share. We've been doing a lot of work actually for I work with a psychiatric access program, and they hired, this is another approach to take, but they actually hired a consultation group to provide consultation on how to address health equity within the context of their network of perinatal psychiatry access programs, and have been building out a series of metrics that all of those programs, it's a different context, but some of it may be applicable. So I can share with you some of the metrics that they're developing to really capture greater amounts of heterogeneity with regard to race, ethnicity, gender identity, religion. They have a lot of indicators that they're building out with that consultation available through the group they've hired.
We partnered with, in my case, Johns Hopkins University School of Medicine, and our center became a medical rotation site. So the residents and the fellows in our case would rotate through our center for their women's health and their community health rotation, because my drug treatment center is really targeting women, is a substance use treatment prevention center for women, but also it's a women's center. So we obviously women and their family and in the community. So the residents and fellows would come from the Johns Hopkins Urban Health Medicine and Pediatric Residency Program, and they would complete a couple of their rotations at our center. This provided our community and our clients with the medical care that they needed, and the supervision, at least the medical supervision, came from Hopkins. I was there, or the residents and fellows were there to learn something different, not medicine at our center. They were there to learn community health, women's health, and their supervision in terms of medicine came from Hopkins. So it was a win-win. It was a win for Hopkins. They provided, the necessary supervision that they had. Our clients had free medical care, and we didn't have to pay the fellows. And before the fellows came, the fellows and the residents, I, we had a volunteer physician, and he was there a couple of days a week. I'm sure we would have to pay him if we wanted him there every day of the week, but he came a couple of days a week, and he wanted to help out. He believed in what we were doing, and he, was licensed. He was able to provide care across the spectrum of care, and it didn't cost us a dime in terms of money. So that may be one thing you might consider.
So one step from our group is, I know we sort of as a panel threw lots of names at you. And so what we'll do is go through this recording, because we did record it. So we'll make it available to you anyway, but we'll also make sure that we send you a list of sort of who was the person who recommended and the contacts, so that as you decide to sort of reach out to others, then it's not super cold handoff, but a warmer handoff as you're sort of moving through and thinking about which areas you want to go to. So that to me was sort of a top of mind first thing that we want to make sure that comes out of this. And then I think some of it's also just sort of up to you guys as you decide to prioritize and move forward. We're happy to sort of put you back into contact with folks on this call, expand the network as needed. And then if you want to do another one of these at some other time, we're happy to do that as well. So all of those options are on the table in terms of next steps.